clinicians, we will often categorize heart failure by different ways, namely the stage of heart failure, with most of us talking about stage C heart failure, current or previous symptoms in somebody who has heart failure. We'll look at, in addition to that, their class of heart failure, most commonly using the New York Heart Association classification to assess functional status, and we'll look at the type of heart failure. Do they have reduced ejection fraction, preserved ejection fraction, mildly reduced ejection fraction? In the world of coding that informs in part reimbursement, we tend to use ICD-10 codes. And so the question was, how do the ICD-10 codes that are assigned when someone is discharged from the hospital with a principal discharge diagnosis of heart failure and a related ICD-10 code to that, how does their ejection fraction match up to that? And how good or poor are we in having alignment between coded data and clinical data, at least as it relates to larger analyses that rely upon ICD-10 codes when doing health services or evaluation of large data sets? I think yes and no. I would say, there are a very large number of ICD-10 codes for diabetes that get into diabetes mellitus that get into specificity of that condition. I think there's fairly good confidence that when someone gets coded with an ICD-10 code as having diabetes, it's a fairly good chance that they have diabetes. And I think the level of discordance is going to be low. I think the challenge is heart failure is a syndrome. There are different types of heart failure, and our current ICD-10 codes for heart failure don't match up to the clinical diagnoses that we use in practice, creating that challenge. And so this is not the first time this has been evaluated previously. There have been other studies that have sought to do it. I believe that this is one of the largest, if not the largest, analyses looking at this degree of concordance or discordance overall. So I'll start by highlighting the fact, and this was presented initially at the European Society of Cardiology earlier this year, is many of the clinicians who are taking care of patients with heart failure will either clearly document this or their documentation, it's inferred, have heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, or heart failure with preserved ejection fraction. And that can be discerned pretty readily if someone writes it, or if in fact you're reviewing the evidence and you look at their ejection fraction. There are principally 5 different ICD-10 categories, if you will, for patients with heart failure. First is systolic heart failure, which you would logically say must match up to heart failure with reduced ejection fraction. Diastolic heart failure, which you would make the argument must match up to heart failure with preserved ejection fraction. There is a systolic and diastolic heart failure. Now, I will say those collectively, those 3 groups of ICD-10 codes only constitute about 10% of all heart failure discharges within our health system. And we looked at over 61,000 patients discharged with heart failure. The other diagnoses that are far more common are hypertensive heart disease with heart failure and hypertensive heart disease with heart failure and chronic kidney disease. Those conditions collectively make up roughly the other just about 90% of heart failure discharges. And it's not obvious to me as a clinician if I document something and a coding team within my health system assigns a diagnosis, a principal discharge ICD-10 diagnosis of hypertensive heart disease with heart failure. What kind of heart failure by a type is that? Is that reduced, preserved ejection fraction? And so we really wanted to figure out what was the ejection fraction, let me be more specific, left ventricular ejection fraction distribution across ICD-10 codes, in particular for those that we don't use in our common clinical vernacular, that being hypertensive heart disease with heart failure and hypertensive heart disease with heart failure and chronic kidney disease. And what does that EF distribution look like, and how big or small is a discordance? our findings, not surprisingly, is that a majority of individuals with systolic heart failure mapped to an ejection fraction, left ventricular ejection fraction less than or equal to 40%. A majority of individuals with diastolic heart failure mapped to an ejection fraction greater than or equal to 50%. Systolic and diastolic heart failure largely mapped to heart failure with a left ventricular ejection fraction less than or equal to 40%. And then when the two largest groups, roughly speaking, about 40% of patients had heart failure with reduced ejection fraction, just under 10% had heart failure with mildly reduced ejection fraction, and about 50% had a heart failure with preserved ejection fraction, defined by an ejection fraction greater than or equal to 50%. So it just calls out two interesting findings. A, whether people appreciate it or not. There was a publication in roughly the last year and a half highlighting this data for Medicare, albeit in years previous, that there was a fundamental shift about 5 years ago in which codes were being most commonly assigned to individuals who are being discharged from the hospital across the United States with heart failure. And in this case, the majority of them are codes that we don't use clinically in our documentation, and the ejection fraction distribution is quite wide. Well, I think the biggest takeaway from this for me is we as clinicians will continue, like our guidelines recommend, both American and European guidelines, to classify individuals with heart failure based upon the stage, their functional status, and their left ventricular ejection fraction. And fundamentally, we have different pharmacologic and device-based therapies that we will allow people to give them to improve outcomes based upon whether they have reduced or preserved ejection fraction principally. But if you are someone that is interested in health services research, you're trying to look at large data sets that are not clinical data sets, not clinical registries, but you're trying to make sense of large administrative data sets of patients with heart failure, and you want to understand the disease trajectory, outcomes, medication utilization, it becomes a challenge if, in fact, there's not an automatic crosswalk to their left ventricular ejection fraction. And where there is a closer crosswalk, it's to systolic heart failure, diastolic heart failure, and systolic and diastolic heart failure. But that constitutes less than 10% or just around 10% of all of the heart failure discharges in our health system. And the data is replicated in a review of Medicare data, a similar fashion. So it just highlights and underscores the limitations of using large administrative data sets to garner insights if you want that level of clinical specificity.